Hi, so this is the study that I've chosen, virtual-based cognitive behavioral therapy versus patient waiting list control for paranoid ideation and social avoidance in patients with psychotic disorders. So a quick overview. The study sought to use the VR technology alongside CBT for patients diagnosed with psychotic disorders, according to the DSM-4, to aid in their social functioning. So that's the headset down the bottom right. It was done by utilizing a single-blind randomized control trial with a treatment as usual control. The authors originally believed that the VR CBT condition would lead to a more time spent with other people and decrease momentary paranoia, perceived social threats, and anxiety. The authors further believe that safety behaviors characterized by behaviors taken in response to social anxiety that help in reducing anxiety, i.e., not looking people in the eye, and social isolation would be reduced by the treatment. So quick look for the background research. This study focused on individuals diagnosed by the DSM-4 for psychotic disorders, for schizophrenia or schizoaffective disorder, and paranoid ideation in the past month. Individuals diagnosed with these disorders tend to have issues in their social functioning, which stops them from forming essential, meaningful connections and halts them from doing stuff like working. Paranoid ideation is key to this. So this refers to the persistent thoughts ones have. This can be of suspicion of, and distrust of people, objects, things, and it's a key aspect in causing the anxiety. See, anxiety that applies to the those behaviors that we talked to before, the safety behaviors. So that's a way of dealing with those anxieties. That's not very helpful. So if you're isolating as a result of the paranoid thoughts, that tends to form a negative spiral, causing worse symptoms and depression and such. So CBT, it's the most common use treatment for this, trying to target those cognitions, so the paranoid ideations, and to affect behavioral change. So a pseudo exposure therapy is kind of what they like to do in CBT, but this is always retrospective and relying on the patient's memories of paranoid past, and also can be affected by bias. By using the VR technology, the authors aim to replicate environments in which a social environment where the therapist would coach, kind of, and aid the individual and stop the address cognitions as they come up. Um, so the hypothesis and methodology. So the study consisted of two randomly assigned conditions. First one being normal condition, so treatment is normal, and VRCBT plus treatment is normal. So the VRCBT condition consisted of 16-hour-long sessions of individual therapy with assessments done at baseline, end of treatment, and 3 months post-treatment. Primary outcome was social participation. This was measured in time spent with others, momentary paranoia, perceived social threats, and momentary anxiety. The sessions themselves would involve a therapist and the participant going through a digital environment, one of 4 digital environments, with a range of a social population, so 0 to 40, and the therapist would coach paranoid and address paranoid thoughts and confront safety behaviors as per individualized CBT. And the method for recording this assessments for the baseline, post-treatment, and follow-up. This was done at the week of which this occurred. And so throughout the week, every day, there'd be 10 random beeps that would go off. At the every beep, they would be instructed to answer a questionnaire through their device. These were on a 7-point Likert scale, usually about 3 questions. So the first hypothesis was that the VRCBT would lead to an increased time spent with other people and decreased negative symptoms. Hypothesis 2, that the safety behaviors and paranoid ideation would be reduced alongside depression and cognitive biases, while social functioning of life and schematic beliefs improved. And hypothesis 3, the changes in safety, behavior, and cognition would mediate the reduction in paranoid ideation. So the results, well, participants first. A total of 116 participants participated in the study, 204 declined. The study had an estimated effect size of 160 with a moderate effect size, or conservative effect size of power about 0.8. So they missed this. So the study was underpowered and can tend to give false positives. So just being aware of that. The amount of time spent with others compared to the control group did not significantly increase throughout the first two assessments. Did slightly increase in the third follow-up assessment for the treatment condition. Compared to the control condition, the VR-CBT condition, there was a large reduction in momentary paranoia, a slight increase in the control group, and momentary anxiety slightly decreased in the VR-CBT condition when compared to the control. There's no significant difference in the momentary paranoia between the two groups, and the safety behaviors were significantly reduced by the VR-CBT condition. So simultaneously with that analysis, there was a mediation analysis that was run. So this was to determine the mediationary effect of the paranoid ideation on safety behaviors and their relationship with social cognitive. So this was found to be significant as well. So the VR-CBT condition had a significant reduction in momentary paranoia and anxiety during social situations at post-treatment and follow-up assessments, which align with the first hypothesis, though there were no significant increase in the time spent with others, except for that follow-up condition that had a slight increase. There was a significant mediation of paranoid ideation between safety behaviors and social cognition. This advances the literature and confirms that the second hypothesis, as these findings suggest that VR-CBT addresses safety behaviors within social situations, which further reduces anxiety. VR-CBT resulted in a large reduction in momentary paranoia and anxiety during social interactions post-follow-up, and overall VR-CBT does not lead to spending more time with others, but helps individuals learn to manage social interactions and rely less on safety behaviors as a result of reducing anxiety and paranoia. So the author's strengths and weaknesses. So their strengths, they thought that the ESM, the experience sampling method that I discussed before, was a particular strength. The pragmatic effectiveness, so the treatment of participants in the study, and the results displaying the effectiveness of the VR-CBT in real-world conditions. Weaknesses, they did not have an active control group. The long-term effects of VR-CBT was not looked at. There were some eligible participants, but they did not participate as they were too frightened to travel to the clinic. So this might bias data, having less significant or less severe population. The study would also not recruit the aimed number of participants, and so had a less power and higher occurrence of false positives. So my criticisms of the study throughout the treatment as usual condition, it did provide a control, but it did not provide a control that would be on par as CBT. So looking through the usual treatment as normal, this one was medications, discussions with a psychiatrist, and like a psychiatric nurse, and that was the basis for the treatment as normal. So it wasn't CBT, even though Garrett et al. Proposed that the desired treatment of this population would probably be looking at CBT, even if it is that retrospective CBT. Anyway, so they missed out on that opportunity to assess CBT and VR-CBT alongside each other to see if that online modality would actually be more effective, or if it was less effective even. Another criticism was the sampling method. So the authors acknowledged having the sessions at the clinic potentially biased results, but they did not potentially look at having an online modality. So this one has been used as well in the VR space, and it's relatively simple as well to other participants at home to less bias that data. So implications as well. Author indicated that the future research be directed at making VR-CBT as affordable as possible. I personally believe that research should be developed to make more of an online and at-home use for this type of treatment with more severe symptoms of social anxiety being helped. And moreover, there is room to differentiate between the CBT and VR-CBT. So future research should aim to compare both those, assessing the effects of this treatment. This would provide ecological validity to the study in the field of VR therapy as a whole. Thank you.